It is now my pleasure to introduce our next speaker, who joins us from the University of Washington in Seattle, Dr. Suzanne Dintzis. So she's a professor of laboratory medicine and pathology at the University of Washington, as I mentioned, and her current clinical areas are, of course, breast and gynecologic pathology, but she is not only interested in that. Her current research projects are not only in breast and GYN, but also now in digital pathology, and also she is exploring the interfaces between quality of care and communication. And actually, this is what it is so important we are discussing about today. Dr. Dintzis is the immediate past president of the Washington State Society of Pathologists. She is also the chair of the Washington State delegation to the CAP House of Delegates and a board member of the Digital Pathology Association. So please join me in welcoming Dr. Dintzis. Thank you.
Great, thank you very much. I just got to meet Dr. Khalifa, and he would be just perfect if only you knew what he was thinking, right? If he didn't express himself. So I think we need to follow up with him to find out what he really is thinking. Just kidding. We've been talking a lot about communication, and I think I agree pretty much entirely with what everybody said. Today we're going to focus on this talk on disclosure of harmful pathology errors, which is the most difficult type of communication. So we'll delve right in. If I can figure out how to, there we go. So nothing to disclose in terms of conflicts of interest. I don't think I have any serious pathology errors to disclose currently. So we're going to talk a little bit about why communication and error disclosure skills. To this audience, I think it's pretty obvious from the preceding lectures. Approaches to error disclosure, and finally some new technology to advance error disclosure training that we're coming up with at the University of Washington. So why communication skills? I like this quote from Shaw: the single biggest problem in communication is the illusion that it has taken place. So I'm not actually communicating with you right now. I'm talking at you, right? And in order for me to know what you're thinking, I'd have to ask you to respond to me, which is why I think talking to clinicians and making sure that we understand what they need is so important. So the topic of diagnosis in healthcare kind of came to the forefront politically from this Institute of Medicine report, which was now published almost a decade ago. And anything that has the title diagnosis in it, take note, laboratorians and pathologists. This was called Improving Diagnosis in Healthcare. And this quote from that report I thought was scary. It is likely that most of us will experience at least one diagnostic error in our lifetime, sometimes with devastating consequences. And the report went on to talk about some of the principles of team-based healthcare, which we've been talking about, right? So shared goals, clear roles, mutual trust, effective communication, measurable processes and outcomes, and specifically for the implications for pathologists. Do you guys know what the Institute of Medicine is? Yeah? Hey, you do. Our residents generally don't. So some people think they're a little out of touch. It's a political group that reports to legislators, but they were responsible, for example, for the call hour restrictions or the hour restrictions for residents. So what they do has a big impact on what they say has a big impact on what we do. And here we are talking about practicing skills that enhance teamwork and interprofessional collaboration. And remember, this is 2015, prepare for increasing communication directly with the patients, which was clairvoyant, maybe not since these were legislators, but the CARE Act makes sure that our reports go directly to the patient, pretty much in real time. So the public has known about the problem with errors for a long time. This Reader's Digest cover is 20 years old now. Fatal hospital mistakes, how to avoid them. And then I always am interested in why sex only gets better. And also, why does Richard Gere look like that dog? So when considering diagnostics errors, what should we communicate? And we've been talking a lot about errors, and I think part of the trouble is what is classified as an error. And that we don't talk about that very much in terms of what we think of as an error and what other people. So I thought I'd just go through some of this. Pathologists and laboratorians think about this probably more than most people. And one way that we classify it is according to outcome. So what happened to the patient because of the adverse event? Was it just an unsafe condition or a near miss that didn't reach the patient, or was there actually harm? And then what level of harm? That's one way to classify an error. We also talk about root cause, right? Root cause analysis. So was it a systems or technical error? Was it a systems or organizational error? Was it a human error? And finally, we talk a lot about testing phase. So pre-analytical, analytical, post-analytical, all of these different ways to classify or think about error. But we're kind of unique in those ways, right? So when you talk to safety professionals, including lawyers, they talk about standard of care. And what that means is, was reasonable care provided to the patient? Would a physician who had the same level of training, given the same circumstances, have reasonably provided the same diagnosis or the same care to that patient, right? That's reasonable care. If the answer is yes, then standard of care was met. If the answer is no, then that's considered negligent care. What about clinicians and patients? They don't care how we classify the events, right? When they're the victim of an error, all of the way you talk about it is not important to them. And in fact, patients' attitudes about error is really broad. So we've done some surveying with patients, and for example, waiting too long in a waiting room to see a doctor, some people would consider that an error, right? So broad classification of error, and we also know that they would really like to see full disclosure, and they worry that healthcare workers are kind of hiding the errors. We also know that there's a performance gap. So harmful errors are often not disclosed to patients, and when the disclosure takes place, it's not always meeting their expectations. This is a survey that my collaborator, Tom Gallagher, put forth to both American and Canadian internists and surgeons many years ago to try to understand their attitudes towards disclosure of serious or harmful pathology errors. And I always like to show this because you can see on the left-hand side, the internists, most of them say that they would definitely disclose a serious error to the patient, so an error that caused harm. But look at the surgeons. They're cowboys. Like, they're definitely going to definitely disclose that error. But then when you look at the content of the disclosure, they're saying they're going to disclose it, but they don't use the word error and they don't give an apology, right? As opposed to the internists who do use the word error, and most of them, or many of them, give an apology. Well, why does that matter? Because these are the people that are disclosing our errors to patients, right? So oftentimes, if you're not present, they're disclosing your error, and you have no idea what they're saying to the patient, what the content of that disclosure is. So COPIC, which is the Colorado Medical Malpractice Insurer, did a program for disclosure and compensation. This is a long time ago, but the data is really interesting. So they looked at over 800 events. So these are serious errors that occurred to patients. And they surveyed both the patients and the physicians about what happened of disclosure of those errors. And when they asked the physicians, and this is the physician giving their idea of disclosure from 0 being a terrible disclosure to 10, they're pretty good. Like, they think they did a pretty good job with disclosure. But when you ask the patients what their experience of the disclosure is, they weren't so convinced that the physicians did that great a job. So this is the gap between what we think we're doing and how we're being perceived. Those are patient care providers, right? So those are people who have direct contact with the patients. We're even more difficult because we have no established doctor-patient relationship, and as I've mentioned, the treating clinician is involved in our errors, even if they're not the errors of the actual treating clinician. So they have to disclose our errors. So we thought we would go ahead and look at the attitudes of pathologists and laboratorians towards disclosure, and we surveyed anatomic pathologists and laboratory medical directors to ask what they thought should be done in the event of different types of errors. So should near misses, minor errors, or serious errors be disclosed? You can see that most anatomic pathologists and laboratorians thought that near misses probably should not be disclosed. Minor errors should probably be disclosed, but they were fairly unanimous that serious errors should be disclosed to patients. When we looked at their experience, which medical errors have you been personally involved with, you can see that a lot of anatomic pathologists have been involved with near misses and minor errors, and quite a few, almost half of them with a serious error. Fewer of the laboratorians with serious errors. But asked if you ever disclosed a serious error to the patient, very few have disclosed a serious error to the patient, and even fewer have been involved in a disclosure of a minor error. So why not? They said, 90% of them, that they should disclose the error, but in fact, clearly they're not. So what are the barriers? Well, traditionally, the institutions have been kind of a deny and defend, share as little detail as possible, review incidents behind closed doors. That's been changing, but we still have a lot of barriers, including these really fragmented data and billing reporting systems, lack of consensus recommendations, fear of litigation, and really difficult cases, right? And when we talked in focus groups to laboratorians and pathologists, it came out pretty clearly that the real reasons that we're not disclosing is because of shame, embarrassment, rationalizations, low confidence in communication skills, and some remaining mixed messages from institutions. So in this paper with my colleague Tom Gallagher, we looked at the fact that we tried to find themes in conversations with pathologists in focus groups, and we found that this ambiguous nature of pathology diagnoses, and we've talked about the gray area. So all of this vagueness in pathology reports is partly because a lot of what we do isn't black and white, right? It's not like it's cancer or not. There's a lot of in between. And patients and clinicians, even our treating clinicians, don't understand this. And also, basically, pathologists and laboratorians are unprepared and to be involved with conversations with patients. These are some quotes from the focus group. One pathologist described a common question: so what's the truth? They may not know that there is no truth. I'll tell you, my social skills are not such that I would ever want to do that, speak directly to the patient. I'm not in pathology because I like meeting people. Some people get offended by this comment and say that that's not necessarily true, and I agree with that, but we do need to admit that most pathologists are not extreme extroverts. Okay, so when you go to disclose a harmful error, a lot of questions come up. When should you approach the treating clinician and the patient? When you've discovered the error? Who do you tell? How do you tell them? Who should be present? So a few years ago, Yael here, who's at Beth Israel, I think it's called Leahy Health Systems now. We used to call it BI Deaconess in Boston, and I wrote a review with recommendations. And this is just one possible approach. If you're confronted with a possible error, the first thing that you can ask yourself is, could there or has there been harm as a result of the error? Because that makes a difference in how you might approach it. If the answer is yes, there could be patient harm, you then go to the reasonable care. So was the care provided in the circumstance reasonable? If the answer is no, then you're in a negligent position, and you should almost definitely disclose that error, at least call your risk management, start to get involved. On the other end of the spectrum, no harm, care is reasonable, then probably most professionals and pathologists would favor no disclosure to the patient as required. So this is just one approach. And then, of course, the middle is the difficult part. The most important part of that is that's confusing. So not only is that flow chart confusing, but getting all of the correct information in place is also incredibly important, and you never want to enter a disclosure unprepared. The worst thing that you can do is go and disclose something as an error and then find out that what you disclosed was an error, right? You've compounded your error by disclosing the wrong thing. So take a breath and do the root cause analysis. Who should speak with patients? Someone who has an existing relationship, someone who can explain what happened, someone who can communicate clearly and empathetically, and how do we put all this together? So Dr. Here and I put together this possible framework, which we called ERIT, which is a disclosure guideline, which includes these elements. And one thing that Tom Gallagher and his colleagues found from surveying a lot of people who have had harm, and all of us are patients, right? We talk about patients and providers, we're all patients. If you think about what you would want, or what you would want for your family if you had been the victim of a serious error, it's really consistent. You want an apology from the person or system that created the error. You want information about what happened. You want why it happened, what were the root causes, what the impact is going to be to the care provided moving forward, what the outcome might be. And finally, one thing that I found surprising, but is really always happens, is what are you going to do to make sure that this doesn't happen to somebody else? These are questions that almost every victim of an error asks. So we'll go through them. Apology, I think you know, an empathetic statement. It can include personal accountability, systems accountability, or both. An empathy statement is, I'm sorry this happened to you. So again, if this is a no harm situation, and care was not negligent, for example, a drug reaction. It's not your fault, but still the patient suffers. You can be empathetic. On the other hand, we take full responsibility for this error, would be an apology if you'd misdiagnosed a cancer. And just to hammer home how important apology is, we made this video it's actually in Boston, so you might hear the Boston accent, which is a patient video.
I imagine that even the thought of coming into our room to apologize would have been a very painful thing for someone.
The head surgeon approached me as if I were a piece of meat. But the biggest issue that I have is that he didn't say he was sorry. You have no idea how far a sorry will go.
I'm not asking for an apology. I'm not asking for an apology at all. Because it's a saying that, it's a Spanish saying, if you're going to say sorry, mean it. If not, don't say it. And I don't want them to say sorry to me because that's what I want to hear.
Why shouldn't they? Anybody should say they're sorry. That's admitting they're not God, though. That's admitting that they're wrong. If they say you're sorry, then if they say you're sorry, but you said you were sorry, maybe they'll sue me if I say I'm sorry, I'm admitting I was wrong. Maybe they'll sue me. I'm admitting I'm wrong. I don't know if any doctor ever admitted they were wrong. I don't know. Not to me, they haven't. Not to me or not to my husband.
If anybody would have acknowledged some accountability, an apology, to actually reach out and connect with us on human terms, in human language, not legalese, not the legality of a letter, primarily a sense that they were sorry and that there is a willingness for them to be vulnerable enough to acknowledge that there might be an imperfection in the system, and to acknowledge by accountability that the system can change.
Every time something went wrong or didn't go perfectly, those times when somebody said either, oh, I'm sorry that didn't go well, or if it was the person involved, ooh, I made a mistake. It was over, it was done with, we moved on.
The person who apologized, I think the reason why his apology was heartfelt and felt genuine is because it was direct. He didn't beat around the bush. He didn't try to cover things over. It was a statement of this is what's happened, and this is what I might have done differently, and this is the outcome. And it was done not in a sense of dismissing my mother and myself. It was done in a spirit of, I'm still working with you. So if something happened, it might not have been the right thing or happened in the right way, but we're still in this partnership. We're still working together. So you didn't feel abandoned, and you didn't feel that he didn't care.
I've seen that video like a million times. It's always powerful to hear it from the patient perspective. And I think we all can relate to the things that these patients were saying. I've had the privilege of being in disclosure situations a number of times as chief of the group, as a designated person, and I always start my disclosure with an apology, just to diffuse. Then I go into the information aspect of what happened. And one approach that I find extremely valuable is to ask the patient or the clinician, depending who you're disclosing to, what is your understanding of what happened? That does two things. It allows you to get their emotional state, so you can tell whether they're angry, whether they're sad, what's going on, so that you can appropriately respond. Because if you just start talking, you're not going to be able to assess that. The other thing is it gets you to understand their, where they are in the spectrum of understanding our profession. So I'm from Seattle. We have a lot of engineers in Seattle, and I can tell you they approach problems really differently. They want different information from non-engineers. They want specifics. One thing that pathologists and laboratorians like to do is jump into very detailed responses. And by asking who you're talking to what they understand about the situation, you can peg the way that you reply to what you think they want to hear by their level of understanding. And then ask them if they want to hear more, not flood them with information from the get-go. Make sure that you're only dealing with facts. Don't speculate. It's very easy to go into spaceland. We are performing an investigation. Here's what we know. If nothing is known yet, we are performing a full investigation. We'll share our findings with you as we learn more. You might ask, why would you go into disclosure if nothing is known yet. I think timing is important. If you've found out that you've been a part of a serious error, you don't want to wait a month to tell the patient and the treating clinician. So it can be a good idea to be timely, but to explain that this is a process and that you're going to be partners in this process. RCA is root cause analysis, why the event happened. Often, Swiss cheese, it's multifactorial, and which is one reason why you don't want to do the disclosure about exactly what happened until you've done the RCA. Because what you think happened often is not the full picture. And you don't want to enter a disclosure giving a wrong answer. So don't speculate. This is something that all patients will ask is, how is this going to affect my care? Often, who's going to pay for this? So we talk about team disclosure. In the event of a serious error, you may want somebody from hospital finance or the treating clinician to be with you, because you're not going to be able to answer those types of questions. This is what it means for you. Again, joint with the clinician, a clinical plan, management hospital services, offer a fair compensation. If you're alone, don't answer those questions. Targets for improvement is something people always ask, changes that can be made to reduce the risk of recurrence. So you should think about this, because I guarantee they're going to ask. So what can you change in your system to make it safer and try to prevent this in the future? So why do patients sue? Generally not because of negligence or harmful outcome, but because of lack of transparency, perceived lack of empathy, perceived withholding of essential information. So this discussion is critical, and there's some good literature now to support this contention that if you speak honestly and openly with patients, they respond very well to that. Your institution will have resources for disclosure, sometimes disclosure training. Risk management is actually a really good resource. They have a lot of information, and they tend to, surgery and medicine have a lot of disclosures, so they're very familiar with this space. Patient relations can be helpful in private practice. Your malpractice insurers can actually be super helpful. They don't want to put out big payouts, so they want to partner with you. And remember that it's not a one-time event. Team discussion, thoughtful provider and patient contact, and make plans for follow-up. There's no easy way I can tell you this, so I'm sending you to someone who can. Sometimes you might not be the person to do the disclosure, so you can find somebody who can help you with that. Okay, so this is super, super difficult. Most of us have not had very much experience with it, and yet ACGME has put out this milestone. Level 4 says participates in or leads communication of error discrepancies. Level 5 provides immediate communication of error and discrepancies. Suggested evaluation method, self-assessment, which we know is so great, right? We think we do a great job disclosing, and direct observation. How many serious errors have any of us been able to directly, the disclosure to directly observe? So the current approaches to teaching these skills are not great. Lectures don't really impart skills. You're not going to run out and do a disclosure. Now, maybe, hopefully, you'll be able to look for resources to help you. Real life practice is infrequent, thank goodness. High stakes, minimal feedback. You could use standardized patients like we do for clinical medical students, but logistically that's pretty hard. Role play, we use that at the University of Washington, but again, fidelity is and feedback is still fairly minimal. So we need a practical, proven, simulated communication practice, followed hopefully by statistically reliable formative feedback. So we created at the University of Washington a video communication assessment module. So what's the VCA? We record scenarios. We watch, I don't understand why it always does that. Let me go back. So we record scenarios of standardized patients on an app or a browser. And then we ask the residents or whoever's using the program to provide audio of how they would respond to that patient. That audio is then sent to 8 to 10 US-based adults using the Amazon Mechanical Turk platform. And then the raters assess, and the user logs back into the app to look at their feedback. What does that look like? Looks something like this. So on the left would be your iPhone or Android. It has a patient. You can watch the video of the patient talking and asking you a question. You can read the case. Then it prompts you to record your audio response to the patient. You can review or redo it as many times as you like, and then submit it to the mTurk platform. The layperson responders listen to your responses, and they assess your communication skills with questions like, was the provider accountable? Did you think they were being honest and sincere? Did they understand how I was feeling? Etc. And then finally, after the results are tallied, you as the person that took the program gets a response. So you get to see the vignette and you get to see how you did. So I don't know if you can see the orange is your score on the bottom. I don't know how to, let's see, can I? Oh, well, it doesn't matter. The orange bar shows your response. The blue bar shows the average peer response, so you can see how you did with respect to your peers. You can listen to your response again if you forget how you sounded or you want to hear what you sounded like. And I think most importantly, you can listen to a highly rated response. So you can hear what the public thinks was a really good response, which I think is something that we often don't provide people, is what sounds good to the public. So obviously, ideally you would like harmed individuals to be the judges. Sorry, this must be on a timer. But it's really hard to find harmed individuals, so we wanted to make sure that the lay people were just as good and reliable at assessment as the experienced harmed individuals. And this first paper on the left, we showed that the assessment was pretty good by lay people. And then we followed up with a paper on how this program did with our residents in helping them with their communication skills. So the study looks something like this. We used 3 types of residents: pathologists who don't have patient contact, OBs who have patient contact and also surgical technical contact, and then IM residents who are patient-facing but not technical specialists. And we divided them into groups 1 and 2. Each of them saw a sad case and an angry case. And then we did a crossover study. So after they got feedback, they saw the other cases, and then they got their final feedback. You can see that there were fewer participants in the second week. Some of that actually was because they thought it was really emotionally challenging and they didn't want to do it again. It's difficult to be yelled at, even if it's an app. We thought it was interesting that residents performed slightly better with angry patients than they did with sad patients. There are a lot of reasons why that could be true. One thing is that it's easier to identify anger, and you can feel we're a little bit better at being trained how to deal with it than we are with sadness. Sadness can be a challenging emotion to acknowledge. Resident skills did improve from round 1 to round 2 in a statistically significant manner. And interestingly, fewer than half of the residents reported prior experience with reporting harm to patients. And you can see that, of course, it varied a lot among the specialties. So Many more OBGYN and internists had direct patient care disclosure. Only 1 of 17 pathology residents reported having had. It's not surprising, but what we did think was interesting was there wasn't any difference in communication ratings based on the specialty or year in training by the public. Residents with prior disclosure experience performed better than those without. So practice helps. So simulated communication training may be particularly beneficial in diagnostic specialties like ours with infrequent real-life practice opportunities. Residents found the cases very realistic, and as I've said, especially the pathology residents struggled. They thought it was emotionally challenging, and they didn't want to return for the second round. I had to do some arm twisting. So we're hoping to have a multi-site pragmatic trial, and we'd love to have apps like this integrated with the curriculum. I think a big gap in our training is we judge each other, but we're all doctors and healthcare providers, and it's important to understand that who we treat are not, and the way they see us is not necessarily the way that we see ourselves. So having judgment from the public in spheres like this, I think, can be incredibly helpful. If we could get some trials going, it would be nice to see what the real-world effectiveness might be and how the feedback can be optimized. So, in summary, communication skills are critical to the delivery of good medical care. Pathologists are not exempt from this requirement. Communication skills are acquired, not innate. Structured training can improve them, and we're hoping that things like this web-based VCA program might help. And finally, I threw this in at the last moment because there was a lot of talk about how to reduce error, and I just wanted to point out right now, so I'm the co-chair of the new guideline for interpretive diagnostic error reduction in cytology and pathology, and the guidelines are things that you guys have been talking about, like number 1, anatomic pathologists should develop procedures for review of pathology cases in order to detect disagreements and potential interpretive errors and to improve patient care. And this guideline is actually now available for public comment up through November 13th on the CAP website, and we would really encourage all of you to comment on the guidelines, what you think might work and what you think might not. We do, as a committee, take into consideration all of the comments, and they are public comments, so it doesn't need to be doctors. If you have friends, acquaintances, colleagues who might be interested in reviewing these, please share the link. And I'd like to acknowledge my collaborators, Yael here, who is now the Chief Quality Officer at Beth Israel Lahey Health, and who helped to make the guidelines for disclosure recommendations. And then at the University of Washington, Tom Gallagher is the director of our Center for Scholarship in Patient Care, Quality and Safety, and did a lot of the surveying work with me. And Andrew White and Karen Brigham have been helping to develop that video communication assessment module. And that's it.
Thank you very much, Dr. Dintzis. So we have at least 5 minutes. Quick thing, just to summarize. So if you are misfortunate, to have to deal with a disclosure because of an error, and keep in mind, the error may not even be yours. It could be somebody else's error in the lab. It could be in the grossing lab. It could be in the histology lab, somewhere else. But you carry the responsibility for the case. So the idea is, if you have to do it, by all means do it. Because I heard you mentioning something about deny and defend. That is not appropriate. By all means do it fully, do it in a timely manner, as quickly as possible, and if you are fortunate enough to establish that connection with the patient, continue and encourage the follow-up with the patient.
So clearly you want to partner with the clinician, right? Because they have their patient facing, so we would never recommend that you disclose an error to the patient without the knowledge and the okay of the clinical team. The first disclosure always has to be the care team. And at that point, I think most people would recommend to ask the care team if you could be present or if you could be part of the disclosure. I've had various answers to that. The problem when they say no is trying to get the follow-up. And I think that's something that very few people get after they've been involved in a serious medical error. As a pathologist or laboratorian, it just goes out there and you never know what was the reaction of the patient, what was the outcome. And I think at least trying to get that follow-up would be very helpful.
Thank you so much for the wonderful presentation. As you know, our world is very dependent on the lab and what happens in the lab. It's kind of like we come at the end, and at the end of the day, our name is on the report. So if you, when that disclosure process starts in your experience, how the pathologist will be responsible for disclosing errors for the patient, for the case. It doesn't matter where the error happens in the lab or the grossing or whatever. So what is your advice to someone who's trying to disclose errors when in fact it wasn't a diagnostic error, it was, say, someone else's error in the lab, but ultimately I understand I am responsible for it.
Right. So we get this question a lot, and for those residents who are not yet in independent practice, please know that when your name is on the bottom line of the report, you own it. And that means basically you own every part of it, which includes the accessioning, the grossing, the histologic preparation. And I mean, I'm not going to pretend that I know the answers to all these questions. This is just my opinion. But I do think that the pathology group needs to take accountability for that work. That doesn't necessarily mean that the pathologist of record, which is the pathologist whose name on the report, needs to be the one to disclose, especially if they just are not feeling that they have those skills. But there should be somebody designated within the group that can do that. Often it's the chief of service. If the chief of service is not the appropriate person, the group could think of appointing a colleague that they think could do that job well. But a pathologist generally needs to be part of that conversation, yeah. Does that answer the question?
Other questions? So Dr. Ade and anybody else?
Yeah, sorry, I came in as you were saying thank you, but I think, you know, the last part of the discussion. So for us at the um-lmp, one of the things that I do and I will encourage everybody to do, when you think there's an error, there's the UMP legal and the patient safety office. Just call them and say, listen, this is what has happened. And they will help you navigate how to disclose, who else to involve, and how to do that involved. So I've involved them even when I don't think there's an error, but I think that there may be an issue, you know, just to give them a heads up. And I think every hospital has the patient safety department, and I think they are a very good resource for us.
Yeah, risk management has been super helpful. And I think that's always the first go-to. It's always a good idea to call them, even if you think that it's no harm to patient. Interestingly, it's never the cases that you think that are going to be a problem that are the problem. I don't know if that's your experience here, but you struggle so on a case, and those aren't the cases that generally come back. It's the ones that you had no idea. I got a letter in my mailbox once from a lawyer from a basal cell carcinoma from the face. You know, this is not a case that you would think would go to litigation. And there was no actual pathology error. But so you can never know what's going to come.
Oh, hi. I'm Michelle Stoffel. I'm pathology and clinical informatics, all subspecialties. So my involvement with error disclosure has been more on the CP side, and those are errors that tend to happen at scale, right, and sometimes need to have batch approaches. Have worked on a number of occasions with our risk and patient relations teams. But as part of that, you know, been involved in multiple processes where pathologists or laboratorians have been asked to be maybe not present in person at disclosure, but available, especially for written statements. And I think this has been a really helpful, you know, experience to learn how to create a written statement that can be shared, and sometimes the clinician will ask us to provide, in my case, often a technical explanation that they can share with the patient. And so I was curious, from your presentation where you're talking about especially the, you know, discomfort of trainees with sometimes being involved in the face-to-face communications, if you've explored, you know, communication via written as exercise. And then the other thing that I would say I've experienced an increase in you know, feedback and coming back to us sometimes via patient relations from the patient portal. We use Epic MyChart. And so that was the other thing I was curious about, is whether you've seen any study or investigation into you know, conversations that are happening at that patient portal level.
Oh, you mean on the electronic medical record? So I haven't personally looked at that. That would be a great big data project, wouldn't it? Where you can, because you can pull, well, there's HIPAA issues with that. But it would be interesting if you could anonymize the comments and pull them to see what patients are saying on the portal. But I don't know the answer to that question. And the first question, I'm sorry, was written. Yeah, no. So I actually personally have not had any experience with written. I usually leave that to my legal team. And at the University of Washington, probably here at Minnesota, our lawyer is the Attorney General for the state of Washington. So that's like, yeah. Don't think I'm going to write anything that won't be taken care of there. But we do telephone conversations. So we have standardized clinicians instead of patients, and the standardized patients love to pretend that they're doctors, by the way. They get really into it and they're really good. And they phone, our residents phone them, and they have to disclose an error to the standardized clinician, and we give them the clinician scripts of what to say. So they have practice with telephone conversations, and we do some role play, but we haven't had written yet. It's a good idea, though. Thanks.
Thank you very much. Thank you very much, Dr. Dintzis.